Hello and welcome to Season 2, Episode 53 of the Physician Assistant Exam Review Podcast. This week, we're going to pick up our discussion of pulmonary issues with obstructive lung disease. This is Brian Wallace here, your host and creator here at Physician Assistant Exam Review. Over at the website, www.physicianassistantexamreview.com, you can find all the show notes and everything else you would need over there on the website to cover all this stuff. A lot of people like to read through the show notes as they listen to the show. That helps get it in through two different senses, which is always helpful. The more senses you can include, the better your memory is, the better your retention is, which is a big focus of what we do here at this show, just to make sure that we're clear. I spent a lot of time through the emails, through the newsletter, through the podcast, covering things about how to improve as a PA student, as a medical student, as a pharm student, as someone studying something that they need to learn. This is not a show that is necessarily focused on practicing medicine, right? We don't talk a lot about the ins and outs and new changes and technologies and different ways you can treat patients. That's really not the focus of what we're doing here. What we're doing here is becoming better students, becoming better test takers, learning the information that we need to learn, certainly, but in that process, becoming better at learning. And if some of that carries over into practice, that's great and certainly helpful because you're going to be learning forever when you're in this field or when you're in any field. But certainly the focus for us is on passing exams. That's the number one issue. And everything else is sort of secondary to that. And that's how I approach all of this and how I think for now, you should approach it as well. That philosophy of covering the material that needs to be covered and not learning every single detail in case it might creep up on one random patient that you have. Not that having all that information isn't helpful and valuable, but it will come with experience. It'll come with time, and trying to learn it all right now, right up front, will overwhelm you and lead you down a path of it's false. It's you'll either have false confidence or no confidence because you're not getting things right. And I think either one of those is bad. So anyway, we focus mainly on passing our tests for now, and we'll fill in the gaps as we go down the road. So we're going to start off today, like I said, with restrictive lung disease. Restrictive lung disease, we've been covering obstructive lung disease, right? So if there's something obstructing the passage of air through the respiratory system, that's obstructive lung disease. Restrictive lung disease will be that the lungs are restricted from expanding all the way. So you get, well, hold on just a second, but you get, the lungs don't fully get to expand. So that's restrictive versus obstructive. And keeping those two things straight in your head is part of what I talk about, getting the basics, understanding the bigger picture, understanding what the ways to think about these things. So the difference between obstructive and restrictive, and holding that idea in your head and picturing what the lungs would look like, or what if you drew an image of the lungs, what they would look like if one had an obstructive disease versus if one had a restrictive disease. And once you have that picture in your head, then you're going to go through and start looking at the specific restrictive diseases or the specific obstructive diseases, once it's clear what that whole terminology means. So we're going to start off today with some priming questions. So let's go ahead and jump into those. Number one, what is a granuloma? This term comes up a lot. What is a granuloma? Number two, in which industry might a worker encounter beryllium? In which industry might a worker encounter beryllium? And lastly, what is the hallmark of a restrictive pulmonary disease on a pulmonary function test? What's the hallmark of restrictive pulmonary disease on a pulmonary function test? And I think about the term restrictive, and this should be pretty straightforward. So I know we just did it, but I like to, repetition I think is a very, I'm just laughing at myself for repeating myself while I'm describing why repetition is important. Repetition is important to your memory. It definitely plays a major role in breaking up the forgetting curve. So real quick, we're going to go over spirometry. Pulmonary function testing. So total lung capacity is the volume of the lungs at maximal inflation. Tidal volume is the volume of air moved in and out of the lungs during normal resting respirations. Vital capacity is the volume of air exhaled slowly after the deepest possible inspiration. Forced vital capacity, FVC, is the volume of air forcefully exhaled after the deepest possible inspiration. Forced expiratory volume in 1 second, or FEV1, is the volume of air which has been exhaled after 1 second of forced expiration. And peak expiratory flow rate is the highest airflow rate during expiration. Now remember, when we did obstructive diseases, we had a big drop in FEV1, that ability to blow out as much air as possible in the shortest period of time, because our lungs were blocked. You could inhale slowly and you could exhale slowly. The actual volumes didn't change, but that FEV1 changed pretty dramatically. So with restrictive pulmonary diseases, we're going to see a little bit different. What we're going to see with restrictive diseases is a drop in total lung capacity. You're going to get those lungs that can't expand fully because they are restricted. So the things that will affect would be forced vital capacity would be down, vital capacity would be down, tidal volume may be down, all of those things that fall under the restrictive idea. All right, so let's go through. We only have a couple here today. Again, I think these are important topics to separate out in your head. So idiopathic pulmonary fibrosis is our first one. This is the development of scar tissue within the lungs. So this is just we don't know why you have scarring in your lungs. Idiopathic pulmonary fibrosis. The clinical presentation here, dyspnea, dry cough, chest discomfort. Labs and studies, you can get fine crackles at the bases. FEV1 is reduced, like we talked about. FVC is reduced. So FEV1 can be reduced, right? It doesn't mean we didn't exclude that before. It wasn't one that I specifically talked about, but FVC is definitely going to be reduced. That makes sense. Lung volumes are reduced across the board. We are restricted because of scarring in the lungs, that those alveoli don't open up all the way, right? Chest x-ray may not be helpful. You need a CT or a wedge biopsy to really get your diagnosis here. Treatment, prednisone may be helpful in slowing that scarring. Oxygen will improve the symptoms. Why does oxygen improve symptoms? Well, because if I can't get the volume in the lungs up, I can increase the oxygenation in that air that's going in, right? So I can get more oxygen in at a lower volume of air. And then lastly, a lung transplant may be necessary. Pneumoconiosis is next. This is a group of diseases which are restrictive and caused by inhalation of specific types of dust, right? So pneumoconiosis is when you inhale something and it scars your lung tissue and clogs it up and makes your lungs unable to expand completely. So the first one in this category we talk about is black lung or coal miner's lung. And obviously this comes from inhaling coal dust. Asbestosis is another one. This is from asbestos, which we used to use for insulation and siding on houses. And when you break it up, it creates this little dust that scars the lungs. It can lead to mesothelioma, but we're not going to go down that road today. Asbestosis is just that scarring from the asbestos in the lungs, from that dust. Silicosis is from silica. Berylliosis is from beryllium, which is associated with aerospace manufacturing, which is certainly a way that they could present it in a test question, which is something that we continually point out here is how things will be presented on your exam. Just like I talked about at the beginning, I don't think the majority of us, depending on, well, you would know better depending on where in the country you are, would see any of these. You know, it depends on what state you're in, what the manufacturing is in that area, and what things they use, if you would see these kind of things. But the idea to me is more, how will they present them on your exam? How will they show up on your test? They're not going to give you berylliosis without something having to do with aerospace manufacturing in the test question. It just seems very unlikely to me. So to me, I group all that stuff together and memorize them that way. Clinical presentation and this is for any of these pneumoconiosis, shortness of breath, and cough. Lab studies and physical exam findings, inspiratory rails, reduced FEV1, reduced FVC, lung volumes are all down. Chest x-ray may be helpful here. Silicosis could have a 2 to 5 millimeter nodule in the middle, upper lung fields with eggshell calcifications. Coal miner's lung has nodular opacities in the upper lung fields and also may have eggshell calcifications. Asbestosis could be irregular parenchymal opacities with pleural abnormalities. And these are typically at the basis of the lungs. So to me, that's how I separate these out, right? Asbestosis, the lung issues on a chest x-ray are going to be at the bases. Silicosis and coal miner's lung are going to be in the upper lung fields or the middle to upper. And that's how I picture this stuff as I go through to study it. I try to branch it off and say, okay, if I have a lung problem and they give me a job in the question stem and I'm not familiar with it, and the chest x-ray shows something in the lower fields, well, I may remember that asbestosis had stuff in the lower lung fields and be able to backtrack it from there and sort of cross-reference it in my own brain. And then a CT scan will obviously be more helpful. Again, here for treatment, we have oxygen will help alleviate the symptoms. I have in big capital letters here, don't smoke. For pneumoconiosis, again, that's how you lead to mesothelioma and some other issues. Obviously, smoking in any of these in general is terrible, but throw in any kind of restrictive lung disease or any lung disease at all, and it compounds the issue dramatically. And then lastly is avoid dust of any type because you don't want to exacerbate the symptoms. Our last one for today is sarcoidosis. This is another one that's just tough to get your head wrapped around. My mom actually has this, and I still don't really get it. This is an inflammatory disease which is characterized by granulomas throughout the body, and the lungs are by far the most common site. So what's a granuloma? I asked that in the very beginning. A granuloma is essentially a bunch of white blood cells, mostly macrophages, that attempt to wall off a foreign body or an invading substance that the immune system finds that it can't get rid of, right? So it can't clear it. So then it just tries to wall it off with this massive white blood cells. That's a granuloma. Sarcoidosis you'll see these granulomas on your chest x-ray. Clinical presentation is fever, dyspnea, routine physical exam with findings on chest x-ray, fatigue, weight loss, dry cough, and skin rashes. Labs and studies, you can get leukopenia, you can get decreased lung volumes, again, like everything else in our restrictive systems. If you have this inflammatory process, it's going to scar and cause some issues in the lungs and make them restrictive. You can get hyaluronopathy. In late disease, you can get nodules or infiltrates in the parenchyma. And on biopsy, you can get these non-caseating granulomas. That's going to be diagnostic for sarcoid. Treatment here, in most cases, observation. And then certainly steroids can help to slow down the process. That was particularly quick. So that was all I wanted to cover for restrictive diseases. We'll get into pleural diseases next time. So today, that's as far as I wanted to get. The one thing I did want to talk about quickly, I guess it doesn't have to be that quickly because we're ahead of schedule, is our study tip for today. Our study tip for today is what not to do on your breaks. Okay, breaks are tremendously important. I spent a lot of time talking about breaks, especially I think in the last issue of the Physician Assistant Exam Scholars newsletter, and how to approach your breaks to get the most out of your brain. I'm off today as I'm recording this from work. Actually, it's Labor Day, so everybody's off today. And I'm recording this. And one thing I did in particular this morning and throughout the day today was I had a lot of writing to do. I had a lot of emails to write. I wanted to get through a lot of work. One thing I very specifically didn't do was pick up my phone. And more importantly than anything else on my phone, I have two games that I play a lot with my kids, and not just with my kids. It's that I like to play them too. Clash of Clans and Clash Royale. And it doesn't matter what the games are. It just matters that they have this, the way that they're played, the way that they're on your phone, the way that they're quick and easy. That playing those leaves sort of a mental drain on your system. You feel like you're doing it to relax and to clear out your head. But the reality is that it actually clogs up your system. And it's a little bit, and well, it's not a little, it's a lot addictive. That's the design of these things, to get you to keep coming back over and over. So what it does is it plants these little seeds in your brain to make you want to go back and check on something, go back and play one more time, or go back and do something else. And I know some of you might not get it with video games, but there are other sources of this. Facebook could be one, Twitter, any of these things. They're all things that are designed to draw your attention back to them and to not let your brain relax, but get your brain to, even 20 minutes, a half an hour later, look for a reason to return to those applications, to those games. So what I do on a day like today, when I know I have a lot of work to do and I want to have a clear head to get it done with, I will not go into any of those games very specifically. And even though it's a little bit of a habit, or my kids are around today, so like, oh, why don't you play with us? I very specifically did not use my phone for any of that stuff today. I stayed completely off of it because I think it makes that big of an impact. And one of the things I talk about a lot is not just that it makes a big impact, it's that you don't know it's making that impact. You don't realize it, but you're getting slowed, you're getting dulled, you're getting distracted. I equate it to somebody having one drink and then getting in the car to drive. It's not that they can't drive, but all of your reaction times are slowed. So although you are not, let's say, significantly impaired after one alcoholic beverage, you are not as good as you would be if you didn't have any. So again, I'm not saying you can't do it. I'm saying to optimize things to make yourself the best. If you had a situation where you had to be at your best, you wouldn't have even a single drink before you got in the car. If you needed to be at your best to do the best studying you could do in the least amount of time, you would not even open your email in the morning. You would not even open your Facebook account in the morning. You would not even open whatever game you're playing on your phone in the morning until all your work was done. Because all of those things create a little mental sludge. They create a little mental loop, a little feedback loop that your part of your brain wants to get back to that keeps you from doing your best. And again, the insidious part is that you think you are doing your best and you're not. That's the part that really concerns me. So I do everything I can to avoid those things on days I know that are going to be longer, that I know are going to need more of my concentration, that I'm not going to want to be spending any part of my brain thinking about something else I should be working on or doing. So anyway, that's our set tip for today is if you've got a big day, avoid any of those things that can leave lingering distractions in your head. Shut down the phone, lock yourself out of it. There are different apps that can keep you from doing that. The screen time app from on iOS is helpful. There may be something similar on Google. I don't know. But that's certainly a way you can go with that. So that'll wrap us up for today. Let's answer our priming questions before we get out of here. What's a granuloma? We talked about that. That's a bunch of macrophages or white blood cells your immune system is using to wall off a foreign invasion that it can't get rid of. In which industry might a worker encounter beryllium? Aerospace. And what is the hallmark of restrictive pulmonary disease? Basically, all of your lung volume issues will be decreased on spirometry, on incentive spirometry. I knew there was a word for that someplace. So that'll wrap us up for today. A little bit of a shorter show today. It's the end of the summer. So everything's been just a little bit behind, which is part of the reason why things are slowed down a little bit today. And next week, we will pick up with pleural diseases, and we'll march right through pulmonary issues. So until then, take care and good luck on your exams.